Good afternoon and welcome to the last session of the day. This is a rapid fire session, so it's going to be short and sharp and interesting. My name is Tasha Gluck. I'm here from the Health Systems Research Unit along with Amir Holfeld, and we're really looking forward to this last session of the day. The theme is research evidence for policy change, and just so you all know how it's going to run, we've got quite short presentations, 7 minutes. We'll probably have time afterwards for one question, clarifying question, and then we'll also have time at the end for some discussion. So without further ado, our first speaker is Prof. Sue Goldstein. She is a public health medicine specialist and managing director at the SAMRC Center for Health Economics and Decision Science, Priceless SA. She has a special interest in research, both quantitative and qualitative, and using evidence to inform policy in the topic areas of health promotion, NCDs, immunization, and child health and protection. So here you go, Sue. Thanks.
This one.
The arrow there. Yeah. And you point it at the screen.
Okay. All right, this is quick fire, so I'm going to talk as fast as I can. So, I think the point about when is evidence useful for policymakers, and I think the one issue is timing, and it's this hurry up and wait. So, good research takes time. What's the cost-effective analysis? Give us this immediate. It doesn't work like that. But policy making again is quite a long process. So they need evidence, people need evidence at specific points. And I'll give you an example of policy-making processes. The amendment for the Liquor Amendment Bill of 2016 is still in process. If we hope it's still in process, nothing's happened. So what's happened with that bill, for example, is that there was evidence that was produced, and then over a period of time, it became out of date. So now they've asked for more evidence, and we think that's industry interference. That's another story. Evidence is not a once-off. Policies, and you can see this, the wheels fall off. And for example, with the SSB tax, at the moment, the sugar industry are very much active in trying to get not only the tax not increased, they're trying to get it off the table altogether. And so we have to constantly be producing evidence which shows the benefits of that kind of thing. Oops. Oh, sorry. Okay. Just to remember people, sorry, the research to policy process, and we have to generate evidence at each part of this policy process. And it's a cycle, so we have to keep on evaluating. Once the policy is hopefully implemented, we have to still evaluate and provide evidence that it's working or not, as the case may be. Taking science to policymakers. The thing is, policymakers don't have time. They're very busy, but you mustn't assume because people don't have time that they're not smart. They're very smart often, and you must not oversimplify. So there's a difference, and you know the story about I didn't have time to make something short because I gave them the long story. They have different expertise to scientists. But they have their own expertise. But the other part is be persistent, and I'm a good example of this. I've been persistent over years and years, not always successfully. So what I also want to just quickly talk about is what is considered as evidence. And although qualitative evidence is now used a lot, particularly in WHO guidelines since 2020, the issue is that people who understand qualitative evidence aren't often sitting on those committees. So I think that's really important. However, when you read a story like this 16-year-old girl from Cosmo City, that kind of story actually speaks very strongly to policymakers. So you can produce all the statistics you like, but if you bring one or two stories like that, it actually speaks much more strongly to them than the 23,000 girls between the age of 10 and 19 who fell pregnant, which totally devastated me. The other thing we talked about earlier, I'm not going to go into, but the extended cost effectiveness analyses, to really look at equity when you're doing cost effectiveness is really important. But hearing the voices of those most affected is also very important. And we've heard very little really about what involving the public in the policy-making process should be and how the evidence should be partly engaging with the public. Multidisciplinary and interdisciplinary research is important. What people are often not aware of or try to ignore or don't engage with are the commercial determinants and also the conflicts of interest. People funded by various industries who are trying to influence the policy-making process. And then there's the issue of evidence. When do you provide the evidence? Should you provide it before peer review? Is that ethical? And certainly industries don't feel the ethical problems of providing their evidence. But I think we really need to think about these pre-publication issues. And where do policymakers, this is a study that was done, I'm almost done anyway. This was a study that was done before, and where policymakers get their evidence from is from their networks, from their trusted sources, from their academic circle of friends, from sources of people I know. I contact the experts and network of people we know. So you have to become one of those people that are a trusted source and network of people that they know. So it's what we call schmoozing. And I'll end there.
Thank you, Sue. Any questions? If not, I have one. Sue, what would you say, in your perspective, are some strategies that you have used to gain the attention of policymakers that we can maybe learn from you?
Well, can you hear me? Yeah. Well, one of the things is pestering them, but the second thing that really gains their attention is bringing community voices. So bringing people. And in fact, the Treasury have said to us before, if you really want to make a policy change, what you must do is get people toying outside of our place. And unfortunately, that's the truth.
Okay, thank you very much. So next up is Dr. Janine Jagathpal, and Janine is the Deputy Director of the Essential Drugs Program with the National Department of Health, and she'll be presenting on research evidence for policy change, advances in national decision-making for UHC. Thank you very much, Janine.
Okay. Yeah. Okay, perfect. Cool. Thank you. So just a disclaimer, I'm not here to give you anything earth-shattering. There's been no new technologies, etc. But I think we welcome the opportunity as the department, and specifically my unit, in terms of reflecting on where we've come. We often don't do that, and we always just take the bad press. We often get told we're going nowhere slowly. There's always this criticism, and as was said today, we also need to celebrate the wins. And I also want to say that the wins and the gains we've had is because of a lot of the people in this room, our partnerships with the MRC, some of our team members are here who are consulted through various NGOs, etc. So I think the point I'm trying to make is that there's advances is because of the collective, not because we've done this alone. And it's taken a long time. I'm hoping we're going to move much faster than 20 years in the next 2 decades, but a lot has been done. So for the sake of speed and time, I'm going to skip through this slide. Sorry. Yeah. So I think it was Nicholas that mentioned the story about GobSat. We always mention that because that's the impression that's been lurking over the years. But I think because we've been communicating a lot and engaging, we're trying to demystify that. That if there's the group of these old people sitting around the table making decisions. There's no consultation. We're sitting in our ivory tower, which is now moved out of town. But It's beyond that. And I think people are realizing that it's not about that. And we keep on saying that because there are still some out there in our very own provinces that think that that's exactly what happens, you know. We see that from the comments we receive from the chapters, who's making the decision. And we get some really, really nasty and hurtful comments, actually. So I'm going to look here because I can't see so nicely. I think the methodology for sure is where we've actually, that's our trump card. That has definitely grown over the last 2 or 3 decades. You see that in the documentation that's coming out, the rigor of the processes. And again, also, that required consultation, stakeholder engagement, and also working with organizations such as the MRC. And, you know, I'll talk about that just now, but can that withstand the evaluation of other health technologies? Because, of course, my presentation is really about the medicine space. Our committee members itself, they've largely been experts. And I think, you know, what has happened is they have really been, they've been people at the coalface, which has been great. So they've seen the patient, but they've also been, you know, there's been strength in terms of skills such as methodology, health economics, etc. And that has grown over time. From the very beginning of this journey, which is great. But I know that we do come under fire around representation from communities and patients, etc. And that's one of the gaps which we're not ignoring and we're acknowledging. It's just how do we, you know, get the patient advocacy groups of the patient to have a seat around the table and what do they have to offer. But it's about getting our current group strengthened, if I can put it that way. I also like to mention as well that we've gotten so far as well because of these experts have contributed as a labor of love. A lot of this work is done mahala, right? And, you know, a comment was made by Dr. Mora about people, you know, contributing to society, and I'd like to use that as an example. A lot of the members that are on committees and outside committees that contribute actually do that for the good of building this process. So kudos to them and utmost respect. It's a very humbling experience for me as well. And yeah, so this has been a 20-year journey. I think before I came along 10 years ago, it was really a one-man show. And our secretariat has expanded to about, okay, we have two full-time resources only, but we managed to get by because we've had additional 5 resources part-time, but also, again, the stakeholders like the MRC, etc. So I think what I'm saying is the power is in the numbers, but it's also the people as well, that you know, the caliber of people that we have in terms of contributing to this process. So where are we now? Again, also, thank you to Cochrane SA as well as the GRADE network as well in terms of strengthening that evidence to decision framework process, and a lot more to be done tomorrow, team. But you've seen it, right? You can see the way decisions are made, how they're made, it's transparent. And again, it's about putting it in the public domain, right? And I think that's what was missing over the last 5 or 6 years. Because obviously we can't share technical minutes, etc., but we do have good documents out there that we can share. And that's actually withstanded some of the legal issues we've been having, etc. Sorry, let me whiz through. Okay. Again, also, this process largely speaks to medicines, but can it stand the test of time as we move to other health technologies as outlined in the bill? Okay, so the future, all right? We've been reflecting and trying to brainstorm in terms of what are the fundamentals in terms of what is needed based on the lessons learned over the last 20 years. We don't have all the answers, and I'd like to just use my famous analogy, which I keep on telling everyone. It's about building a house. For me, what's the bricks? What's the cement? What's the walls? What's the roof for us to put this house together? I don't know what it's going to look like. We have an idea in terms of the footprint from the NHI bill around the HTA unit, the guideline development process, etc. But what are those fundamentals? And that's what our team has been focusing on. So as we carry on building the medicine process, we focus on those areas which will ensure we have a robust foundation, a strong structure of what is needed, no matter what it's going to look like and how many years it's going to take. So that's really, this slide is about the focus areas. It's about stakeholder engagement, expanding to other technologies. And I just want to particularly mention the stakeholder engagement. It's not just about meeting people. We need to figure out how do we talk the same language right, with different stakeholders. On our committees, we have private sector representatives. How do we work together collaboratively on a piece of work? And that's where the difficulty comes in. When we talk about conflict of interest, when we talk about, your own perverse incentives, etc., how are we going to speak the same language to be able to get a product that is universal for all 9 provinces and for the public and private sectors? So in closing, how do we get there? We do believe that we can build on the existing processes on governance, methodology, stakeholder engagement, and the list goes on. We're not saying we have the answer to everything, but we definitely have enough information and enough intelligence to build the future. I think I've covered it. Thank you.
Okay, thank you very much, Janine. I wonder if there are any questions. We have time for maybe 1 or 2 questions. Anyone? Okay. So just considering some time, we'll move on to our next speaker. So our next speaker is my dear colleague Solange de Rauw. She is a senior scientist at in the Health Systems Research Unit at SAMRC, and is the co-director of Kosher Nutrition and Kosher in Africa. I'm going to hand it over to you. Thanks. Thanks.
Thanks, Amir, and hi, everyone. Okay. So today I'm going to be presenting on some lessons from the Global Evidence Local Adaptation Project on adapting guidelines for newborn and child health in South Africa. Just to say, I have no conflicts of interest in relation to this presentation, and the project I'm going to be talking about was funded by EDCTP. So despite improvements in the health of newborn and children in sub-Saharan Africa, many countries have not yet met the Sustainable Development Goal related to under 5 mortality, with poverty-related diseases being the leading cause of death in this population. Affordable, effective, and accessible health care and social care is important to address the issue. And in order to help with that, we need evidence-informed and contextually appropriate guidelines that can help bridge the gap between research and care. But developing guidelines can be quite a complex and resource-intensive process, and we need to find ways of adapting, adopting, and developing guidelines in ways that minimize waste, that avoid duplication, and that are efficient. So the Global Evidence Local Adaptation Project, or GELA for short, aim to maximize uptake of research evidence through increasing the capacity of researchers and decision makers to use global and local research and guidelines to develop locally relevant guidelines on newborn and child health in Malawi, South Africa, and Nigeria. And through this work, also to add value to the guideline program of work by WHO. The scope of the project encompassed a series of work packages, starting with identifying priorities for guidelines, gathering the evidence on those priorities that would then be presented to a national panel that would deliberate on the recommendations for those priorities, and then those would be shared in many different bespoke ways to all the relevant stakeholders. It also encompassed a capacity building work package where we wanted to build the capacity of researchers and decision makers in all aspects of guideline development, as well as a monitoring and evaluation work around what we can learn from implementing this type of project. And today, in this presentation, I'm going to specifically be talking about or sharing experiences of producing research evidence for decision-making in this project in South Africa, so focusing particularly on those first 3 work packages. Just to acknowledge that there was a huge team involved in the work that I'm going to be talking today about, and that we also partnered with the Department of Health for the project. So we started with doing a landscape analysis of newborn and child health guidelines published in South Africa between 2017 and 2022. We identified 23 guidelines, and from those we could see that, yes, there are a lot of guidelines that were published recently and that address a lot of topics, but there were still some gaps in terms of content as well as in terms of reporting, with the main issues there being around rigor of development and editorial independence. We then embarked on a priority setting process to identify what are the priorities in the country for guideline development on newborn and child health. And we implemented best practice methods for priority setting, including stakeholder engagement, online surveys for broader stakeholder engagement, consensus meetings with our national steering group. And then this was a very long and dynamic and iterative process, at the end of which we identified 3 priority topics. So 2 of them focused on anemia prevention in infants and children through iron supplementation or multiple micronutrient powders, and 1 of them focused on supporting caregivers of preterm and low birth weight infants after they are discharged from the hospital. The next step was to gather the evidence for these priorities. And we followed the GRADE guideline development process, where we first try to identify, is there an existing guideline that is relevant and high quality that we can base what we want to do on? And within that guideline, are there evidence syntheses that underpin the recommendations in the guideline that we could use? And this was not only looking at effectiveness reviews of what works, but also looking at qualitative evidence syntheses of contextual factors, such as, is the intervention feasible, acceptable, what are the resource costs, etc., and also economic evaluations. If needed, we would update those reviews. If there was no review linked to the guideline, we would scope the literature for reviews that we could use that were high quality. And as a last resort, we would conduct a new synthesis with the view that this would be a more effective approach. So for example, with the question on family support for preterm and low birth weight babies, we focused specifically on home visits and peer support interventions based on our consultations with colleagues nationally. And then we did find a WHO guideline that had a relevant recommendation that matched what we wanted to do. Within that guideline, there was effectiveness evidence. Woo, this is very sensitive. There was effectiveness evidence. So there was a systematic review that had been done that informed the recommendation, but it was out of date, so we decided to update it for the project. We also found qualitative evidence underpinning that guideline or the recommendations in the guideline, but then we felt we needed more locally contextual data around views and experiences, particularly relating to home visits and peer support interventions in South Africa. So we did a local contextualized rapid qualitative evidence syntheses. And then we conducted a scoping review of economic evaluations and a costing analyses of training and supervision of community health workers. So all of that evidence informed the next step, which was when national guideline development groups met to review the evidence and deliberate on the recommendations that would then be embedded in national policy. Specifically, the evidence helped to inform evidence to decision frameworks, criteria such as benefits and harms, resources required, equity, acceptability, etc., that would guide the panel members to make their recommendation. This was a very important process to build relationships between researchers and policymakers, and also provided an opportunity to build the capacity of guideline methodologists in the country. So just finally, some of the lessons we learned along the way were that it's so essential to partner and co-create with researchers and policymakers and civil society throughout the process. It's so important to find the policy window where we can fit so that the work we'll produce will be relevant for the country. That the priority setting process was quite long, very iterative, dynamic, required a lot of refining and took longer than expected, but it was we learned a lot from it. Also, a great methodology for systematic reviews and guidelines is quite a new concept for a lot of partners. And there were steep learning curves and new skills needed, for example, in terms of adapting qualitative evidence for guidelines. But overall, it was, there was excellent research team collaboration and a lot of opportunities for on-the-go learning. Thank you.
Okay, thank you very much, Solange. Again, any questions? Yeah.
Sorry, so just let me repeat the question. So is there a repository of recommendations that have been graded using the grade system and that can be accessed? And do grade recommendations vary by country?
Thank you. So I think in terms of a repository, I'm aware of repositories for specific conditions, like there's the COVID rec map, where you can find that. A lot of the WHO guidelines are graded, and they would be available in the guidelines repository of WHO, but I'm not aware of any specific repository where you can find all graded guidelines. And the second question is that a guideline will vary by context, because although effectiveness evidence might be the same, a lot of the contextual factors may differ. So each country might review the same quantitative effectiveness evidence, but their contextual factors will be different, and so their final recommendation might be different.
Great, thank you very much. I'm going to move on to our next speaker, Dr. Wanga Zembe, who is a senior specialist scientist also with the Health Systems Research Unit. Thank you.
Thank you, Amin. I heard this thing is sensitive, so I hope. Oh, okay. Yeah, I'm not very good with these things. Good afternoon, colleagues. So I'm going to give a rather breathless 5-minute presentation on a topic that was very big, certainly the report that came out of it, so I'm going to try and be fairly quick. I'm presenting on behalf of myself and 2 other co-investigators, and indeed, one of them, Namhla Sikwebu, was sitting here, but I see she left. But it was the 3 of us who did this work. It's not doing it. Oh, I told you. So, and these were supposed to pop up one by one. Yeah, I need some capacity building in slides development. So this is based on, so these findings are based on work that was commissioned by the WHO very late last year. I was in a meeting in Finland. The WHO person who's in charge of TB approached me on the side and said, can you do this work in the next 3 months? Which ended up being 1 month because of the bureaucracy of setting up the contract with the MRC. And so we were commissioned to conduct a review of social protection mechanisms in South Africa for TB. And the review, which was one of 5 countries, was meant to inform the WHO's end TB strategy, where social protection has been identified as an area of priority. And our brief was to particularly and specifically explore, document the availability, coverage, and adequacy of social protection measures for TB in South Africa. So our methods were a combination of a desktop review of TB epidemiology and social protection instruments in South Africa. And then we also conducted a secondary analysis of our own data that we'd been collecting for about 5 years as part of Liva van Leeuwen, who's my PhD student, on the burden of TB on patients and households. So we then analyzed this data, which was about 100 transcripts, to bring in the flavor within the report of the lived experiences of people with TB when attempting to access social protection in this country. We then also supplemented that with data from interviews with key informants, both from the 5 years of work as well as new interviews that I conducted. I thought my slides were very dull, so that's the one picture that you get, which shows SASA, and indeed part of the findings are around how difficult it is, not only for TB patients, but essentially for all low-income South Africans who find themselves needing to access social protection in this context. The key findings, which are also supposed to come one by one, were that there actually isn't any TB-specific social protection measures or interventions in South Africa. We don't have that. And even for me, who eats, sleeps, breathes, it's my entire, focus, social protection, I was rather surprised by that. And in fact, that particular finding, before we even sort of delved deep into the policy review, we came from one of the key informants that I interviewed for this. And he said, like right straight at the start of the interview, he's like, well, TB patients aren't really supposed to receive grants, because the disability grant, which is the one grant that they would be eligible for, the eligibility for it was changed to say it needs to be an illness that's 6 months or longer. So TB now is 6 months, and then the new treatment regimens, which are great, but what they do mean is that shortening now the time period, I think it's now going to be 4 months. It chucks them out entirely. And yet TB is fundamentally a disease of poverty. And so the mismatch between how the policies that have been built to capture, and in South Africa, we've done better than our counterparts in terms of Africa, the region, and in the global South generally, in trying to adopt a life course approach to social security and to social protection measures. Essentially what the findings show is that entire population, which is extremely vulnerable, before they contract TB, their vulnerability is what makes them susceptible to TB in the first place, that they're not catered for. We also saw that even the TB sensitive, because now we had to actually move our social protection measures from the TB specific, which is where they would normally be located, to the TB sensitive column in terms of what measures we have, that even those are inaccessible essentially. And the findings identified particular barriers which were both within the health system and outside it. And essentially within the health system, the main one, since I'm nearly out of time, the main one is the fact that the diagnosis, the management is entirely done from a biomedical perspective on a condition that is fundamentally structural. So it's sort of mind-boggling, really. And so the absence of a multidisciplinary approach, of a multisectoral response in trying to deal and manage TB means that, it traps us in a circular, vicious cycle of contracting it. Many of the people that we've interviewed over these 5 years, many times, have had 6, 7 incidents of TB in their lifetime. It's recurring. And that's because it's still treated very much as a physiological condition that you get sick from, that you can pop a pill for, and that then, the assumption is that you'll be okay. And so now it's doing the thing it was supposed to do, but rather rushed. So the lessons and implications that we then brought out in the report was that there should be TB-specific social protection programs, including other, non-cash interventions such as food parcels, mental health, which has come through very much in the research that we've done over the years. It's a great need for people with TB and their families. That there should be an adoption of a multidisciplinary approach that goes beyond medical doctors, and that there should be a comprehensive package of cash and in-kind services, as I said, that will not only address, though, the patient, the person with TB, but will take into consideration the environment they come from. And we end off in that report by essentially saying that such a comprehensive response is what would ensure that we not only achieve better treatment outcomes, which is what the health system is obsessed with, but that actually we avert the catastrophic costs that come with having a disease of this kind, and then more importantly for my interest, that we ensure recovery and thriving of the person with TB and their household and families. Thanks. Ooh.
Thank you, Wanga, for sharing your reflections. Any questions for Wanga? Okay, I'll take the 2 at the back over there. Thank you.
Hi, thanks very much for a great presentation. My question is literally to do with sort of the last slide that you were talking about. And I was interested to hear your thoughts. My own work is on benefit package design. And I was interested to see the comment that you think there should be TB-specific social protections provided. Now, one of the things that we're looking at in the benefit package design with NHI is to look at benefit packages, individual benefits defined in different ways as they are meaningful to different stakeholders in the health system. And I wondered And one of the things we're also trying to do is to shift away from a purely disease-based focus to more of a systems focus.
Yeah.
So I wondered how you would feel about someone amending that statement to say something along the lines of social protection that's linked to some feature of TB that makes them means that they require additional help. So a vulnerability status or something else that's not it's not about having the disease, it's about a feature of their life or their environment that would make them eligible and require, as you say, additional help. Would you be open to something like that?
No, absolutely. And indeed, so I often feel like I have to make an apology each time I present on the TB work because I really am not a TB specialist in any shape or form. And indeed, the rest of my studies, which very much focus on children and therefore on nutrition, I'm not a nutritionist or an expert on that either. So I'm not actually interested in conditions either. And indeed, a social determinants of framework, an ideal one for South Africa, which I would have made that comment when Helen was talking earlier, would be one where upon interfacing with the health system, ideally before, but if we're talking even about promotion and prevention, or at least then reducing, alleviating, that upon interfacing with the health system, there would be a type of population registry that would capture all the demographic characteristics of each person who comes in. So their income, their employment, their living conditions, access to housing, all these other factors that we know are determinants of health and well-being. So I would definitely, in fact, I thought of that with the essential package. I wonder if they're even considering a true social determinants of health type of input into that. Thanks.
Thanks, Wanga. I think one more question from Kim at the back. Thanks.
Hi, everyone. My name is Kim McWilkin. Yeah, very similar to, and you covered that already, the kind of what was in that TB sensitive kind of column that could be applied broader. And the other thing was, in terms of the instruments that you were looking for, did they have to be kind of national comprehensive or like a high level, how comprehensive were they? And in the qualitative interviews, did you come across access to certain instruments that were maybe implemented at like a grassroots level or like NGOs, or I'm thinking like around the food security kind of area?
Thanks. Yeah, indeed. So just to quickly say, the TB sensitive column would include cash transfers, would include in-kind transfers, that's transport, food parcels, nutritional supplements, housing. I mean, if you really want to impact on TB, housing conditions, access to sanitation, to adequate water and sanitation, and so on. Those would be the sensitive instruments because they're not directly impacting on TB, which would be the specific ones. And then in terms of the second component of your question, which was? I was just wondering about, so you found no instruments that were... Yes. Was it happening at a much smaller scale that people were actually accessing, but just in this kind of fragmented... Yes, indeed. So first of all, in many health facilities, there's some variation of that. So in the Langa Clinic, for instance, there's a soup kitchen that the doctor at one point, when he was removed, that was gone, a doctor formed a relationship with the soup kitchen. And so he would refer people who would get a full 7 colors lunch after taking treatment. But the fundamental, and there've been variations of that. There's the porridge, the supplement that's given to some and not others, and that's where the problem is. It's up to the doctor. In the 5 years that we collected the data, and I'm the one who did all the qualitative interviews, a lot of the times I would sit across a patient. I'll never forget the mom who was giving birth the Monday, and I was doing the interview on Friday. And I thought she was 4 months, 20 weeks or 24 weeks ahead. And she was full on 40 weeks, essentially. And she was skeletal. You could blow her away with your breath. And I just could not understand it. And when I went out to the nurses after that interview, I said, how is she not receiving anything? None of the supplements that were provided by the clinic, she wasn't being referred to that soup kitchen. She wasn't receiving anything. She had not been, the doctor would not refer her for the disability grant. This is why I'm saying the concentration of the power to decide, if you leave it to just one person, it's exactly, Prof. It's ridiculous. It doesn't work. So indeed, there's a sort of patch of some things that are happening here and there, but it's not uniform, it's not standardized, and it's definitely not fair.
Thank you, Wanga, and thank you for those questions. Next up, we've got Dr. Donella Beseda. Donella is an epidemiologist and health economist working in the areas of maternal and child health services, HIV, TB, mental health, and human resources for health. Thanks, Donella.
Thank you. It sounds nice to be called doctor. I just finished, so I appreciate it. But also, speaking of acknowledgement, this work wouldn't be possible also without my supervisor, Prof. Crick Lund, who is kindly here as well. And there's nothing rapid about this work. I have to say it was probably born out of the Life Esidimeni tragedy in 2016 and kind of ignited a process of highlighting the neglect of mental health services in South Africa and the fact that we needed to do something about it. So I'm happy to be able to share this and also acknowledge our colleague as well, Sumay Dokrat, who was part of this process and isn't here. Ooh, sorry. Ooh, ah, oh my God, what do I do? Make it go back? Oh, okay, sorry. Okay. So how do we make the case for investing in mental health services? So we first started by wanting to highlight what the current burden of mental health services in South Africa is. And what it highlighted as well is that we actually don't have nationally representative data on the prevalence of mental health services, speaking about neglect. And so the last study that was done was in 2002. And since then, we've had to rely on kind of global modeling exercises to make us understand what the burden is. Nevertheless, we know the burden is significant, and we know that it is the leading contributor of years lived with disability in South Africa and in many other low and middle income settings, and also contributes a lot of disability in South Africa. And we know that several factors are contributing to this high burden. We know that it's a huge comorbidity factor with mental health and other infectious diseases, namely HIV, TB, as colleagues were saying, as well as a lot of the non-communicable diseases, diabetes, hypertension. We know globally that it contributes to significantly lost output, a kind of economic growth outputs in globally, and it's been estimated about $1 trillion annually are lost to mental health. And we've costed this for South Africa, which I'll present later. And so then what happened is what government needed to understand is before we start saying how much we should be investing in mental health services, we needed to understand how much are we currently investing. And again, this speaks to a lack of information systems that are able to answer that question. What we needed to do is actually do national level data collection to understand the data collection systems we have for mental health services are wholly inadequate. We have 4 indicators in our district health information systems for mental health services, and those are people under and over the ages of 18 that have been screened for mental health and then have been given a service for mental health. By those indicators, we have no way of knowing what the conditions are, what the true burden is, and what kind of services they're being given. And so we wanted to know how much we're spending. And what we found out is about 5% of the health budget is being spent on mental health services. And why? Sorry. Oh, and why that by global recommendations, that's actually not bad. I mean, it's on the lower end of what globally recommended norms are saying we should be spending. But what it showed is we have an over 92% treatment gap for mental health services in South Africa. So what does that speak to? It speaks to the inefficiency of how we're spending our services. And when we looked at where the resources were distributed, less than 10% was being invested at the primary health care service, and close to 50% is spent at the specialized service level. So that just speaks to how inequitable and inefficient our services are. And also, despite 5% of the national health budget being spent, there's huge inequities across provinces. Some of the provinces, such as Mpumalanga, is spending about 2%, and they don't even have a specialized psychiatric hospital in that province. We also know, given the lack of community-based services in South Africa, there's a huge investment in readmission, and that's another inefficiency in how we're spending our services. About 25% readmission rate, consuming close to 20% of investments for mental health services. And also we have very long length of stays. And that speaks to a lack of community-based services to allow discharge and continuity of care. So then we want to look at what are the priorities for investing in mental health services. And we have a global synthesis as well as a local synthesis of literature and evidence as to where we should be investing. And it really speaks to a lot of strategies around investing at the primary healthcare level. Recognizing mental health as cornerstone of the UHC agenda, that we need to reduce inefficiencies by investing at the primary healthcare service, investing in task shifting strategies, amplifying training for our generalist workers because we have a complete absence of specialist workers working at these levels, and then initiating early interventions as well and integrating mental health services within broader primary healthcare services as well. And of course, the active engagement of people living with these conditions in the political process and in the so as we know, and we're speaking a lot about UHC, and it's recognizing that you cannot achieve UHC without also investing in mental health services, and also the fact that you need a multi-sectoral response to address mental health services as well because of its interlink with poverty and all the other. Wow, that 5 minutes goes quick. And so you have to integrate that, and also recognizing as part of the post-pandemic recovery agenda, not only has mental health already affected the population, but we know that there's been an increase also in the burden, particularly of post-traumatic stress, anxiety, and depressive disorders, and we need to also quantify that. So then what we needed to do is assemble an investment case for mental health services. And so this has been developed over several years of dialogue with the Department of Health, with Treasury. There was a mental health think tank that was established. We engaged with the provinces as well to actually understand what local priorities are. And then we wanted to model what the costs and benefits of a package of mental health services would be. And it's looking at a broad range of conditions, not just common mental health conditions, but also the severe conditions, childhood disorders, and the broad range. And what we hope that this would build towards, first of all, in the medium term or short term, conditional grant funding. And this is not to verticalize mental health services, but ensure that it's serviced in parity with other conditions so that once we have integration within the NHI, it's adequately integrated. And then we also wanted to kind of improve at the time, it was developing the new mental health strategy. We wanted to inform the new mental health strategy. And ideally, this work is to inform the benefit package under an NHI. And so what do we know from the return on investment? There are huge returns on investment, particularly around the common mental health disorders, as well as epilepsy, as well as social emotional learning programs for children in schools, and also addressing risky alcohol use. So a lot of the early interventions actually are the ones that have the highest returns. And that's not to say that other interventions shouldn't be invested in, but these are the ones that have the highest returns. What's important as well is we costed inaction in South Africa. And so that's always nice to kind of reflect when you're going into Treasury and saying this is how much you should be investing. You can reflect also to say this is how much you'd lose if you don't. And when you compare that, actually, we lose 4% of our GDP annually by not addressing mental health services. In reflection, we actually are asking for the full scale-up package, about 0.4% of GDP is what's being requested. And so it's always a good, healthy reflection. And so finally, what did we do? We hope to inform the kind of policy translation space. And so ideally, we'd like to believe that some of this work informed the development of the new policy and strategic plan. And we've seen some of the recognition, first of all, of the mental health, the economic consequences of mental health, some of the recommendations and strategies we've identified in the return on investment analysis was incorporated into this new strategic plan. And where are we at now? So we have a policy, but as always, the policy needs to be costed again. And so we need the commitment of financial resources. And we also need capacity building to actually develop implementation plans. As often we say, we have really good plans, but not a lot of implementation. And so this is where we are at the moment. And I'm going to end. Thank you.
Thanks, Donella. That was very short and sharp and really great, so thank you. Any questions for Donella? Okay, got a question down here for, who's got a mic? Ari, just here.
Thanks, that was excellent. I'm just curious to understand, and maybe you obviously didn't have time to discuss this, but in terms of the task shifting And I'm particularly interested in understanding if you looked at and what the findings were in shifting that tasks to the clinical associate levels in terms of providing mental health care, and how that then speaks to the ROI in terms of bringing down the cost and improving the investment in mental health.
Thanks for the question. We didn't actually model service delivery with clinical associates, unfortunately, but we did look at kind of, nurse-initiated SSRIs, so allow them to initiate care at the primary health care level, increase utilization of B-Psych counselors, which have been established long ago by the department, but actually a very underutilized cadre, use of community healthcare workers. But yeah, certainly, I mean, this is, what we modeled was also through clinical consultation with experts, and this is what came up. But certainly, I think there's room to look at alternative mechanisms of service delivery and what cadres we can use, certainly, in the future. And Craig, feel free at any point to answer some of these questions as well.
Okay, I think, Craig, do you want to? Irene, will you? Oh, Michelle's got it, okay.
Yeah, thanks for the question on clinical associates. So Sahindra Mudli has just done a very nice PhD at the University of Pretoria, looking at task shifting to clinical associates for mental health. So there's fantastic mapping out, consultation with a whole range of different stakeholders and recommendations about how that could happen. So if you want to have a look at that. Thanks.
Thanks. Michael.
Thanks, Tasha. Hi, everyone. Michael from Division of Epi and Biostats at Stellenbosch University. My question is actually to the whole panel, and it's really around, I think, what Laura spoke about regarding accessibility and transparency of evidence in the work that the panel showcased, which I think is absolutely amazing. So the question really is, to the panel, and I think anyone can answer, is around, what steps have you taken to increase or address transparency and accessibility of the evidence, or the evidence demand, evidence supply that you've presented, specifically in relation to whether it's had any impact beyond kind of the spaces that you've seen currently. Thanks.
Thanks for that question. So at Priceless, we've been very actively engaged in giving evidence to policymakers. And I think there are two very successful areas that we've managed. The one is in salt regulation, and the other is in the SSB tax, and which is called the Health Promotion Levy. And that's where we've learned a lot of how we've engaged, because the SSB tax at the moment, I mean, it's been going on since 2016, and we had to provide the evidence prior to that. So this is a long-term project. But I don't know if I've answered your question, but it's been an engagement with a whole range of stakeholders. It's not just Treasury, for example. It's not just Department of Health, civil society. It's a whole range of stakeholders over a long period of time.
If I can answer also briefly, I mean, first of all, a lot of this work was actually commissioned.
Oh my goodness.
By the Department of Health. So really the work was embedded. And I think, I mean, in terms of data access, I think we do experience quite a lot as researchers being able to access data. And so given that we had from the inception kind of the letter from the DG commissioning this work, being able to do the national data collection, getting into hospitals and districts and getting that data, I think was really facilitated because we had that partnership with the department. And every step of the way, I mean, I think what's also important is we have an obligation to feed back data to the people that are generating the data for us. And so after the first phase where we did the costing work, we went back into the provinces and relayed the findings to validate whether what we were finding was true and what the kind of contextual issues around what we were seeing, what those were answering. I mean, and then again, as I said, we engaged with Treasury and the Department of Health at many phases, as well as the mental health think tank, which was established to support this work. But nevertheless, this work is still, in terms of the uptake, I still grapple with what happened from the time that this report was generated to the uptake. And maybe at the time where you start saying this is the actual bill, that's where things go quiet. But yeah, I think there was some successes, and I think we still have to engage more, but we certainly try to have it be very consultative. And I think at least it generated a lot of access to data. And I think really maybe where the work really happens also is at the provincial level, and we really got a lot of positive kind of feedback at that level, and we still have kind of independent people writing us to say we need this level of support and that sort of thing. And so maybe you develop those relationships outside of national, and that also supports the work.
So if I understood your question correctly, Michael, I think this is where we have not advanced, right? I think, and that's a big issue. I mean, I spoke early on about the advances, but this is actually one of the big issues that we need to address urgently. In fact, this is actually the priority in terms of, transparency of the information as well and easy access. And the reason why I'm saying that is because of that. I spoke about the 20-year journey. We've come to a point now where we've got to look back in previous recommendations made, where was the evidence, etc., because there's been different people over time. And we're finding that the need for that is actually very urgent, or yesterday. So for me, actually, in terms of our consultation with stakeholders, like the MRC and other people who are working with us, for me, that is actually the number one priority, because we actually at the point where we need to go back in time. Most of the time, we are just fortunate that the team we have are like very OCD, and we keep information quite, and we share information, but if we didn't have that, we'd have a big problem. So yeah, for me, that is a big issue, actually one of the hugest issues. Thanks.
I'm not sure if I should respond. I think because it's a bit of a complex picture. So my work mainly involves trying to bring together two departments, the Department of Health and the Department of Social Development. And they're not too keen on working with each other. So it's very so with this report, for instance, the WHO one, the release of it was delayed because somebody was unhappy that, in a sense, the recommendations are speaking to new tools having to be devised or developed, and more money needing to be spent. So I think it's just, I still find it quite complex. So the people who were most excited was WHO headquarters, Geneva, about the findings. And initially they were like, oh my gosh, we're going to put this out. And then when they talked to the two parties, they're like, okay, we think we'll, so it was incorporated into the 5-country study report. But in terms of actions coming from that, it was sort of shelved, really. And the other problem or challenge with doing work on social determinants, it's the toughest aspect that you need to intervene on. What Prof. Mashabela was talking about in the morning. Health promotion and prevention, it's much more difficult because it requires political will, it requires massive resources, it requires bringing people together who may not necessarily want to be together. So I just think I find it much more difficult, almost as difficult as, for instance, mental health, another very difficult topic to get people, and then by people I mean the people with power, to act on.
And just to add to that, the vested interests. And I think one of the things about transparency in terms of evidence is making sure that your evidence gets out to the public. It's not just the policymakers, because the public, once they have a little bit more power in using that evidence.
And perhaps I can just add that in the context of the Gala project, the intention, and even when you follow guideline development process, is to ensure that there is transparency across all aspects of the project. So we've published all the reports related to how we did priority setting, who was involved, how we got there. We've got all the reviews are going to be publicly available, and hopefully once we sort out how to fit our recommendation into the national guideline, that will also be made available. But our goal is to our goal is to ensure that every step of the way is documented and transparently reported to everyone who may want to see any of the documents, even the evidence to decision tables, and what the guideline panel deliberated on and what they decided regarding each aspect, and how it all led to the recommendation that was made at the end of the process.
Thanks for that question, Michael. And I just want to open the floor to other questions to the panel. This is your last chance for the day before the gala meeting. There's a question. So please don't hold back. Ask your questions. We've got time. Got a great panel.
Yeah.
Thank you very much. I had a question. I'm having trouble articulating it, but you know, some of my current responsibility is training the next generation, and not just students, but emerging scholars. And I'm always struck by how do we think about research? And the institutional incentives are all geared, even the way I was presented was number of publications, you know, and all our institutions are geared to writing grants. But the way I see research is, for research to have impact, someone said it's a political approach, is that you need to have the relationships. Even that, those relationships frame your question before you even start writing the grant or the publication. But I wanted the panel to reflect on how do we change, how can we, I don't see the type of engaged scholarship we need to have. We're now using this fancy language of research to evidence, but it's how do we reform our institutions to reward that kind of research rather than, I feel like the publications, the grants will come, but that foundation, if you don't have that foundation, it doesn't, you'll have publications, but the publications will, that's not impact. So how do we get back to centering our institutions to really value that foundation, and maybe to speak to your experience of how do we elevate rewards for that kind of research?
Does anyone want to take a stab at that? Yeah, we can take.
I mean, I think that's an incredibly difficult question, and I'm not a good person to ask because I'm not that steeped in academia. But I mean, I think that is part of the answer in a way, is that research shouldn't just be about academia. It needs to be rooted in all of the work that one does, even within in the NGO sector. And I think that the responsibility of academia is to try and support that. But I don't know how you shift universities. No clue.
I mean, I think actually that's, you know, I think, thank you for that comment. It is difficult because it's not built in. I think the MRC is going very far as an institution in trying to sort of turn that around. But I'll speak from my own experience. Certainly, as an early researcher, there really wasn't, it was extremely difficult to know where to start with establishing. I mean, so what we used to do, which is what I did, was with each project, you had to put out a policy brief, but there wasn't a process of knowing who read it, who wants it, who, you know, so I've had to establish those relationships myself. And a few years ago, I started to, especially, it's much more harder for me, I have to confess, to establish relationships with government, really hard. But I've established relationships with civil society organizations, which become part of the grant writing process, if possible. And a project that Yang and I are currently involved in actually even has a government partner. And it's such a game changer in how you think. So we feed results into, you know, during our briefings with the Western Cape province every single time. And it's a tense space, it's a difficult space because they're not used to this way of working either. But it does work. So I do think that perhaps there's changes, and as I say, for the institution that I work for, we have particular KRAs that speak to knowledge translation, to knowledge sharing. But I don't know if you're just coming straight from, you've just finished your PhD, would you know what to do? I think it's very difficult.
Yeah, I just wanted to agree with all of that and to say that it's part of how we are measured as researchers in whatever institution we are, and it's about the people that are running the institutions deciding what should we measure researchers against, and not just our publications, but where have our publications informed policy, where have we contributed. And as Wanga said, I think MRC is doing better in that space, but I think it's other institutions in the country changing the way they see the work, and also academia then helping young researchers to build those relationships. So the older generation can help the younger generation and bridge the gap, build the relationships, and it's strengthening partnerships with the stakeholders that need the evidence. And because we have such diverse practices and what evidence is used, who needs what, it's strengthening the evidence used in the policy space, and then linking those policymakers that need the evidence for their decisions to the different people that can provide it.
So if I can reflect on a policy perspective, there's so many questions that need answering. And I understand that's the time, and it's also this as well, and that's what we've been told. I mean, over the years, we've tried to have meetings with heads of schools, different academic schools, etc. And nothing has come of it because around the time and the money issue, etc. But there's so many questions that needs to be answered. And when I spoke about stakeholders early on, it includes the academic space as well. And rightly said, Solange as well, we need to figure out how we're going to actually make that a formalized, a more formalized and continuous relationship, like we do with the MRC. If I think of myself and my own personal experience, I was started off as a student. I was like, put as a student in a committee, and I was like, I don't know what was going on, but you learn on the job, and you can see there's a gain on each side. But I think we really need to think about it, because I'm concerned, like even from the implementation aspect, which is a huge, huge gap, right? We don't know what's going on out there, right? Until we have the systems in place to actually be able to monitor what's happening across the public sector in terms of, if I look at medicines, we need that research. So we need to think about how we're going to formalize this, because there's so many questions that need to be answered. And from a policy perspective, we don't actually have the time to answer those questions, and that's a fact. And we actually guess it. Yeah, that's true.
Great. There was another question, I think, from Crick.
I don't have, I mean, I agree with colleagues, and to say we did push hard as well with our KRAs in recognition that, it's not enough to recognize just the grants and kind of and publications. Just to say also with publications, I think, we need to expand our understanding as to what form of publication carries actually a lot of weight. Like these peer-reviewed journals are very inaccessible to the wider audience, particularly the ones that are not open access. And so I think we need to also maybe place more merit in more open access forums that, that you can translate things. I mean, as someone also who struggles with length, being able to synthesize everything in 3,500 words that actually has richness of detail, I think, shortchanges a lot of the research that we do. So yeah, and maybe also in terms of, I mean, what I do struggle as well is kind of our cycle of evaluation is yearly cycle. So it creates this rush factor to write a paper as quickly as possible so that I can get my publication in, and so some sort of recognition that that work takes a long time to synthesize and therefore write up in a way that's, gives credence to the work that was done as well. Yeah.
So I think a new innovation, I'm calling it new because it's sort of, I've only seen it recently. So with that particular project, which is funded, that Young and I are working on, which is funded by the IDRC Canada, the funder actually made it compulsory to bring a policy partner, a civil society partner. So I think that's, yes, so it makes it so much easier, because from the get-go, you need to identify who your policy partner is. And in fact, part of the outputs as the project, I mean, this project just started beginning of the year, and we've already had to put together 2 policy briefs. So they sit on you. They want to know, when are you putting it out? When are you translating this evidence into something that can be used? Where's the take up? What is government saying? So I think if funders, because that's a problem, you are driven by what, it's very difficult, for instance, to say, we'll take questions from the government if they can be funded. Because often the government wants to give you, has research questions, but they can't fund, those questions themselves. And so where are you going to get the money for that? We follow the money because we're forced to do that.
Okay, last question. There was a question just before you, Younger.
Sorry, I just wanted to ask Wanga, thanks so much for your presentation. I'm really interested in this whole issue of social protection. I mean, I've been thinking about it a lot in relation to mental health, but it was so interesting to hear your thoughts in relation to TB. And for me, it raises a question about the potential for research around who carries the cost and where is the return on investment across different sectors. So we've started to think about this in relation to mental health, but how would it apply in the case of TB or NCDs, for example? So if social protection could potentially improve TB outcomes, what is the health gain, and also what is the financial gain to the health sector? So I'd be interested to hear your thoughts on that. Thanks.
Those are the Wellcome Trust unfunded proposals that was submitted with costing and evaluation components. Though, that's the dream work, right, that we would want to do. But particularly with the work of the last 5 years by Liva, the PhD student I was talking about, the focus of her PhD has been, what is the cost to the individual in the household? And that's never spoken about, and not in terms of catastrophic, economic costs. What is the burden? So we changed it. We use the word burden. What's the burden on the person and the household that they? And I think that's another sort of much more nuanced way of seeing who carries the cost. I think above all the sectors we're referring to, it's individuals and their families and their households that really carry the cost.
Yeah, please.
Something that you said just struck me is that Janine's got all these questions, and many of us are grant funded. So, and we are funded in a way that very often international funders, and they are not interested in South African questions that you ask. They really aren't. They want these global big things, and we struggle to get important things funded through so I think maybe the MRC can have some global influence because this is really a difficult thing for us to actually get funded what you need.
Great.
So many things. I mean, we put in a proposal for surgical package, benefits package, and they said, well, they're not interested. It's just South African stuff.
Any more comments? Or maybe one more question? Oh, there's 2 at the back, and then that's it. It's Kim and JM there at the back.
The mute one. Is it on? Yeah, just a reflection as well. And it's also about the duplication of effort, and you feel like you're restarting from scratch again every time. And and maybe thinking about the funders and that example of having those stakeholders involved from the beginning, but also then I guess maybe not funders and also the technical assistance space. It was also talked about earlier about making those results public. And having worked on the same kind of analysis over and over again, not being able to share information, and then restarting the same process over again. So the idea of that transparency of information at different levels from different stakeholders, I'm not sure there's an answer to that, but I think that's a frustration from a policy point of view.
Thanks, Kim. Shall we take James' question and then we can do last responses from the panel?
Yeah, it's not a question, but a comment, and it specifically related to the costs to an individual who's engaging with the health system. I posted this morning a link to the latest Becky Cisa Health Beat, which gives a story, a case study of somebody who got fairly good care in terms of procedure, but the long-term care for the consumables that they needed to manage their chronic condition wasn't there, and every time she was having to spend money to get to the hospital, and then there'd be a stock out. And I think from my perspective, sort of working on benefit packages, one of the things that I would like to see is that we start to think about, particularly long-term and chronic care or NCDs, is that we start to think about benefits in this care pathway format, so that you understand not just the condition and whether it's a treatment or a prevention-related service over time, but that you understand all the elements that go in, and particularly how many visits it is and where they need to come. Because while we all typically go to the provider side costing and the economic evaluation, that kind of approach allows you to look at the patient side costing. How many times are they being required to go to the hospital or to the facility to get things? It also allows you to mainline within these care pathways mental health or rehab as well. But I just thought your point about not forgetting about the cost to the patient and the societal costs more broadly is something that often doesn't get talked about and should do.
Thanks, James. I think one last comment from Younger. You've been waiting a while. There's a mic coming. We're ready to hear from you.
Respond to Asha's very important question, and I also teach at the university, and it is a concern of mine that the kind of training that we're doing, the kind of scholars that we're producing, and as Wanga said, you look at the kind of scholar that, how your own scholarship was developed, that we were not trained to think in critical ways. We were not trained to think of our job as scholars as the work of changing and transforming society. It was nowhere in the curricula. All kinds of very nice words used all over, but really there wasn't. One had to forge their own path of transformation of the individual, which is what you really need. It's transformed individuals who become scholars that do the kind of work that needs to be done. And our universities, and that's why I want to come back full time to the MRC, because I think that space has made me so cynical. Our universities, the neoliberal, capitalist, market-oriented nature of our universities simply makes no room for that. There is no room for the development and production of next-generation scholars who are critical thinkers who want to transform society. That's just not one of the things that they're going to tick. But I think it begins in the way, I think that the change really lies with ourselves as individuals. So the kind of work that you've done to conscientize yourself, to ensure that your approach to research, to knowledge production is not superficial. It is not feeding some machine so that you push out all these without doing the work of wrestling. I was reflecting the other day and I said, I did my undergraduate and postgraduate studies at UCT, and it is one of the top-ranked institutions in the country and in the world. And I wasn't taught the work of wrestling. I had to find that out myself. The work of wrestling as an institute, which is necessary in the production of a meaningful change-making intellectual project, of wrestling, of questioning, of wondering, of digging way deep to think about stuff. That's why I decided I'm not going to talk, because
we do need to end the session.
It may not be the nicest way to end the session too.
But there's plenty of time.
Can I just do a pip? So I just want to add something, because I think that what's critical is that it's a multidisciplinary thing. And I think for me, what I've learned throughout my career, self-taught as you were, But what is critical is working with lawyers, for example, in that space, understanding, okay, this is how policy changes work, etc. So I think we as health people tend to stick to ourselves, and sometimes we let in a few economists every now and then. But it's really important to have a proper multidisciplinary approach.
Thanks. So, thank you. Just for the panelists, one last sentence if you would want it. You don't have to take it, but if you would like it, anyone? Otherwise, I don't know if you all agree with me, but this has been quite an amazing session. Janine, do you want to go for it? Just use the
My new buzzword is fragmentation. So I think we need to stop the fragmentation. I know we can't achieve it all in a day, but we can work on pieces of work together and use that as proof of concepts, test case, or whatever it might be, because the proof is in the pudding. The bowl says it all, but how are we going to do it and how are we going to actualize it is a different story. And from my side, that's my aha moment, that we need to actually now do and see what works and what doesn't work.
Thanks, Janine. Yeah, so I think just to end off the session, a few takeaways, which, I just kept writing down, so I'm not going to get it all. But I think it's been quite amazing how we've seen how research can impact policy change. And we've also heard how there are some challenges, which we know, we've been talking about it today, within government settings, within the area of social protection, mental health, and also how important it is for research to speak to policy, like your TB population with the disability grant, as well as to include the patient voice, what they value and prefer, what is important to them. Are we researching topics that actually matter to the people that are receiving the treatment or the intervention? And then also how important it is for information systems to bring it all together. We need to invest in primary care. We need to be excited about the high caliber of people that we have that are able to do these things. How amazing to have a whole day hearing about all the different things people are doing. And then also just how do we change the way research and learning about research and training research looks. And I suppose it all comes back to what Prof. Moshobela said this morning, is that it comes back to the values. Who or what are we doing it for at the grassroots? That may be the question we need to start with, when we maybe not following the money, but following the need, although it is tricky in our space. So I just want to say a very big thank you to our speakers. I think they've been absolutely excellent. Thank you for those who traveled here. And I'm just going to hand over now to Tamara.
Hi, at the top. Hi, tech folk. We're going to switch over to my laptop, please. Thank you. Wow. Thank you, everyone, for being here today. It's such a pleasure to see all of you, to be here together. I want to acknowledge our government colleagues that have come through today. My boss, Liesel Zulko, is the VP at the MRC. The many colleagues from within and outside the MRC working in the health policy and systems space. It's been an invigorating, interesting, inspiring day. And I thought I would ask you, just checking on that session, I've still got a minute or two. I would like to hear from you for a moment. So you're going to take out your phones again. Because I'm thinking I do want to capture a little bit about what were some of the highlights or take-homes for you today. Because I know what I've taken away. In fact, I'm just in a bamboozle of kind of making sure the day runs smoothly and trying to take it all in. We've got rapporteurs reporting on and capturing each of the sessions, and we have recordings of each of the sessions that we'll be able to share. And we might, my colleague Mark at Cochrane South Africa mentioned, maybe we should capture some of this in some kind of a report from the event. So we'll be in touch with all of you if you'd be interested in that. But if you can take a moment to add your take-home learning from the symposium. don't know. Now? Gosh, sorry, guys. Thank you for paying attention. Testing you. Now, do you need to see the code again? Skip it. If you, Solange, you're seeing it. You are my. Oh, that's amazing. Mm-hmm. Passion. I never thought I'd be saying that at the end of a health policy and systems research day, but I'm very happy to be. Passion, transparency, equity, and social justice. Oh, you don't see it? Oh. My PowerPoint is closed. I'm not showing my PowerPoint, I'm showing my Chrome. Should I duplicate my screen or something? Okay, hang on. It was fine this morning, I promise. Duplicate, duplicate. Extend, no. Duplicate. Keep. Let's see. Ah, okay. No to avoidable mistakes. Focused research, team effort, passion, transparency, equity, centrality of primary care, actionable research. So the purpose of a day today, we covered such a spectrum of research, really. I mean, the intention wasn't a deep dive, it was a sharing more broadly across the different units in the country. And there's so much more going on that we didn't even begin to touch on. So I'm really grateful to all the speakers who've come through today and to the team who helped put it together. But we're going to capture a lot of what's coming through here. But certainly social justice is something that drives what we do. We've spoken from the start of the day about humanity, about values, about whenever we proceed with things to have something that our unit has spoken about is to have Africa-led, Southern-led, equity-focused, Africa-centered research driving the agenda rather than the other way around. As you know, people talk about the challenges, but we still need to, push back on what we can fund. I was reading a paper that was circulated on our unit recently about how global health, 99% of it is funded global health research about matters for the world, and particularly for LMICs. Most of the money goes to high-income countries. Bill and Melinda Gates, more than 80% of their funding is held by PIs in high-income countries. What? So, you can see what inspires us to change. So, I'm now back on my screen. Yes, I'm back on my screen. Okay. So I'm so grateful to everyone who's been involved. I want to especially thank the whole unit. Everyone has been, you've seen people have been running around doing a million different things, but particularly the organizing committee. So we've got Zoe, Wanga, Tanya, Solange, Michelle, Kim, Danella, Dash, Amir. You've done an amazing job supporting the scientific program together. And I also want to give a special thanks to Joy Oliver. Everyone here probably spoke to Joy at some point as she helped with sorting and arranging. So I just want to give a big round of applause to the whole unit. And I was, as you were speaking, and I was kind of feeling inspired myself, I was reminded of our vision as a unit. building stronger health and social care systems through collaborative health policy and systems research that promotes equity and transformation. And it's so amazing to have that reflected in the community. And certainly the point of all of this is collaboration. We can't do it. We can't nearly do it justice on our own. There's so much to be done, and we can't afford the duplication. So I'm really looking forward to continuing this journey with you. And I hope you'll all come and join for some light refreshment upstairs in the Flamingo restaurant. Thank you, everyone.